released Indian Dementia Report WHO 2012 and a report on dementia, a public health priority. He also has a creative talent of writing in the local newspapers, which has been collected together as musings into a book, and I would like to invite him to chair the session. Thank you.
Introductions are always embarrassing. Thank you, Dr. Veera. The purpose of this session was, most of us run clinical services, but running a pediatric neurology clinical service is not like running any other clinical service. Like many other difficult to run services, it does require a multidisciplinary approach. It requires many kinds of skills coming together. And I'm looking forward to learning from Professor Mink how we should be doing this. And I believe that this is going to be a discussion session. So, Professor Mink.
Well, I don't know if I should presume to tell you how you should be doing this, but let me just start with a couple of thoughts and then maybe have some discussion. I spend about half of my clinical life caring for children with Tourette syndrome. And Tourette syndrome is, as you know, a complex neuropsychiatric disorder that, although it's defined by the presence of tics, and as a movement disorder specialist, I think of that as a common movement disorder, it's a different kind of movement disorder from many of the others because it's often preceded by this sense that you have to do the movement. As we talked about yesterday, about half of individuals with Tourette syndrome have obsessive compulsive symptoms or anxiety or both. About half of children have inattention, distractibility, hyperactivity, impulsivity, all the symptoms of attention deficit hyperactivity disorder. And probably 20% of them have what we often call rage episodes. And these are episodes that are probably, of all the symptoms, most bothersome to the family, where a child will, usually in the setting of someone in the position of power, a parent, telling them, no, you can't do that right now. And they will have a toddler temper tantrum, even though they're 10 or 11 or 12 years old, and can be very, very disruptive. And this is also kind of triggered by a sense of things not being right. So the tics are preceded by a sense that I don't feel right. The obsessive compulsive symptoms are often preceded by a need to do something to make things right. And these rage episodes are preceded by that. And it's a disorder that really crosses the boundaries between psychiatry and neurology. In the United States, in about half of the cities, most children with Tourette syndrome are cared for by psychiatrists. In about half of the cities, most are cared for by neurologists. I know in different parts of Western Europe, there are some countries where it's a psychiatric disorder, and there are some countries where it's a neurologic disorder. And I think, and I don't know in India, but I think that if you look worldwide, it is, in some parts of the world, viewed as a psychiatric condition and others a neurologic condition. And I think it's a great example of something that really spans that. From that example, though, I think we can also look at a variety of other neurologic disorders that have prominent behavioral and cognitive aspects that we often view as psychiatric. And we can look at a number of classic psychiatric disorders and point to prominent neurologic features. I think that most individuals with schizophrenia, for example, though prior to taking antipsychotic medications, have abnormal patterns of movement. And sometimes I think they actually cause some disruption. And so, again, many, many examples of this. Now, the other third leg of what was in the title of this workshop is rehabilitation. And that's also something where the other side of my clinical life is in dystonia and in juvenile neuroceroid lipofuscinosis, or Batten disease. And those are conditions that are very often progressive. And very often we don't have effective symptom-modifying therapy. Even for dystonia, although deep brain stimulation can help quite a bit in some forms, our medications are moderately effective, and often rehabilitation strategies are needed or adaptive strategies are needed to help people maintain independent lives. Often, those rehabilitation doctors are separate. The physical medicine rehabilitation physicians, the therapists, and I think too often we say, okay, we're through with the acute neurology, now let's have them go see the rehab people, and we wash our hands of it, and that's it. But I think that they're important to really have a good comprehensive service or clinic, both in adult neurology and in pediatric neurology, but maybe especially in pediatric neurology, to have a system, to have a arrangement to foster, I think, better collaboration and better interaction among the psychiatrists and the neurologists and the rehabilitation specialists with all of the ancillary therapy services, because we really inform each other and there aren't these clear, strict boundaries between our different disciplines. So just as thoughts, I don't know to what extent. A lot of this is the way the different specialties can interact, the way they do act, are often defined by, in the United States, by payment. If you're a mental health provider, you don't get, there are completely different rules for how payments are made by insurance companies than if you are a neurologist. And there are different rules for reimbursing for therapy services than for acute medical services. In other parts of the world, it's more cultural or social, where the definitions are more based on convention rather than anything. And really, when you think about it, the division between psychiatry and neurology goes back about 120 years. And there was kind of an artificial distinction around the time of Freud and Charcot, very artificial distinction between what we now call psychiatry and what we now call neurology, when it's really all about the brain. It's all about the nervous system. I shouldn't leave the muscles out of this because the muscles are important, but it's all about the neuromuscular system. It's all about the nervous system, both central and peripheral, and whether it's the behavioral aspects or the motor aspects or the sensory aspects or the cognitive aspects. I think that they are all part of the same system, and so to provide the best care for our patients, I think we really need to find a way to work better to bring those different disciplines together. So that's just kind of organizing thoughts. I'd be interested to learn a little bit about how you do it, because I know you do it. and maybe we can talk about some strategies for trying to, it's not just collaborating with our colleagues, it's building the system. And a system that will foster better interaction, better collaboration, rather than having the rehab hospital over here and having the neurology institute here and having the psychiatric institution here. I think that the more we can bring them together rather than apart, the more our patients will benefit and the more we'll benefit.
Thank you for those really nice opening thoughts. Just to share one or two insights that we have developed over time. When I trained at Queen Square, my experience came from epilepsy neuropsychiatry, doing the clinics with Professor Trimble, and Tourette syndrome, doing the clinic with Mary Robertson. And therefore, exactly the same experience that many of these patients, yes, they had a neurological problem that needed dealing with, but they had a number of associated problems that we would call neuropsychiatric or neurobehavioral that needed to be managed as well. And one of the challenges was that you couldn't just manage this doing office practice across a table. You needed to do much more than office practice across a table. That was one learning that we had in that setting. The other learning was that you very often with these populations have to deal with services that go beyond medicine. Very often with these children, you're talking to the school, for the school to understand what the requirements are. Very often with these children, you have to talk to various elements of social services. People have to be educated about being registered as disabled. People have to be educated about what their entitlements are in the society that they live in and how to access those entitlements. And in the Indian setting, that is even more important because the entitlements are few and can often be very difficult to access because nothing comes easily in India. Everything is a breach extraction. There is no such thing as a normal delivery with government. So these were the challenges that we saw. And one of the learnings also was that as a doctor running a clinic, it's very difficult for you to do all this on your own. You simply don't have either the time or the skill sets to deliver this entire comprehensive service. So what we have done over the period of the last decade, and the basis was already laid by Professor Srinivas, because we've had in the neurology department in VHS, we've had physiotherapists and social workers for many, many years. So what we did was we operationalized that into a model. And the model starts when a patient comes to clinic. So essentially, everyone who comes to clinic, unless they are a simple patient who can be dismissed with a prescription and things to do, all other more complex patients go through a multidisciplinary assessment. So people are seen by the physical therapist, people are seen by the social worker, people are seen by the psychologist if required, and essentially we then develop, and we've now expanded that. We now have an occupational therapist on our team, and we've expanded those services to include other multidisciplinary professionals. Each person does an assessment which is reasonably standardized and which has built within it some outcome measures. To give you a simple example, we might complete the child behavior checklist on all the patients. So that then gives you a standard assessment of the child's behavior, which is then applied across different children. And you get data which you can compare. You can also go back to it and see what happened to this child from the time that I first saw this child and the child was assessed. And so on. So you do have each discipline has its own assessments that can be applied. What we have learned over a period of time is that at intake, doing this gives us a very good idea of the rehabilitation needs of that individual. And rehabilitation is really trying to restore optimal quality of life and give that person the best chance of being well. So this gives us a very decent framework of information to work with. That's the first thing. The second thing that we have learned is that it helps us set goals to work with, because otherwise what happens, you're always problem solving or troubleshooting. You're not actually working towards a positive goal. The positive goal obviously is the person thriving, in this case the child thriving in the society that the child is in. Little things like, for example, when you write to the school and say that let's put together a statement of special needs for this child, that is often very helpful. Many schools are actually willing to do these things, but nobody tells them that this child may have special needs which need to be statemented. And once you statement, then there's a bilateral recognition. Similarly, when we write to, we give all patients a copy of their records. The reason being that in the Indian system, record keeping, accessing records can often be a challenge. So when we write these multidisciplinary assessments, patients walk away with copies of those assessments which then belong to them, which they can present, because invariably they will go shopping. Invariably they will end up seeing other professionals. At least what we saw when we saw them, we'd like to try and document. And then these form the basis of any outpatient or inpatient rehabilitation that we then offer this child. It could be an after-school rehabilitation program. It could be, a therapeutic program during holidays and vacations. We have many children with, for example, hyperactivity who keep coming back to us, or autistic spectrum disorder, or borderline forms of learning issues, who keep coming back to us during their vacations, because they can actually at some level thrive in the normal school environment. So it's this network that we feel that a multidisciplinary team is able to build, and the team comes with its own skill sets. I mean, as a doctor, I am not always trained in advocacy. I'm not always trained in social factors. I'm not always trained to think about the family and look at what in the family is enabling or disabling this child. And that, I think, is what the rest of the team brings to the table. So those would be opening thoughts, really.
If I could just use one specific example, I talked a little bit yesterday about behavioral intervention for tics. And let me just talk for a minute about what the behavioral scientists are calling now comprehensive behavioral intervention for tics. It's really based on something called habit reversal therapy. And the reason I want to use this example is it really, what unites much of what we do is learning and practice. And so habit reversal therapy, let's take, for example, a child who has a neck jerking tic. Okay, many neck jerking tics, and often in the younger children in particular, if you ask why do you do that, they say, I don't know, it just happens. Older children can identify an urge. The younger kids may not be able to, but if you can help them identify an urge, then they can respond to that urge by doing a competing response and prevent that tic from happening. So let me give you an example. There's a training video that Doug Woods, who's one of the leading practitioners of this therapy, shows. And this is a young boy, 9 or 10-year-old boy, who has many tics, but the one that bothers him is he jerks his neck like this. And Dr. Woods asks him, do you have any warning? And he says, no, it just happens. He said, okay, I want to try something. As soon as you know you have jerked your neck, or as soon as you know you're about to jerk your neck, I want you to hold your hand up. And they're talking about baseball. I imagine in India you could talk about cricket. All the favorite players, all the teams and what the scores have been. And the boy jerks his neck, and Dr. Wood says, now remember, when you jerk your neck, you hold your hand up. Over 5 minutes, you see this boy go from jerking his neck and holding his hand up to holding his hand up and then jerking his neck. Even though he couldn't describe, I feel a tightness or I feel an urge, he somehow was able to identify something that happened in his brain prior to the movement. And once he identified that and could hold up his hand and say, okay, I know I'm about to do it, now before he does the tic, he can do something else. So then the next part is, what's a competing response? Something you can learn, something you can practice to prevent that movement. And what he identified, and it usually helps if the patient himself or herself can identify the competing response, is if he contracted his sternocleidomastoid bilaterally, he couldn't jerk his neck because his neck was now held stiffly. On the other hand, you can do that and carry on a conversation so it doesn't really interfere. Now, the subjective experience of patients who try this is for about 2 weeks, it's a high cognitive load. They have to think, don't jerk, tighten, don't jerk, tighten. And then it becomes more and more automatic. It's just like learning a new piece of music on an instrument, or moving to a new town or neighborhood, learning how to get to the grocery store or how to get to work. The first couple of times you do it, you have to think, okay, I'm going to go 5 corners and I'm going to turn right, and then I'm going to go half a mile and turn left. And then after a while, you go to work and you don't even think about it. It becomes automatic. So psychologists do this. But there aren't enough psychologists around, and not enough psychologists trained really in the behavioral therapy techniques that we can provide this kind of therapy for all children. Wow. Okay. So, who does this kind of thing routinely? Occupational therapists do this routinely. They have patients who have stroke or orthopedic injury or other types of disability, and they have to now get the patient to learn how to dress themselves differently. And so we have started to work with occupational therapists to take what comes to them as part of their profession, modify it very slightly to employ this behavioral technique, and now we employ the occupational therapists in helping children with tics learn how to do competing responses. It's it's really right in the center of what occupational therapists do, because it's learning-based practice and improvement. And that's what this therapy for tics is. So I think it's a great example of something that can really span, the more, I guess, cognitive and emotional aspects of what we do in psychology and psychiatry, the motor aspects of the tics in neurology, and then the more therapy services-oriented practice to really provide this comprehensive strategy for helping to get over these symptoms. And that can probably be employed in many areas where we don't right now, is to really use a lot of these practice-based improvements that we can see in a number of conditions. And that's probably neuromuscular disorders. The physical therapists work not just to prevent contractures, but to help children and adults learn strategies so that they can get through the day and get through the world despite having weakness, or despite having stiffness, or despite having a paresis.
perhaps just share a case vignette so that we can kind of discuss around patients as well. We had this young lad who came to us. He's about 12 years old, and he was adopted, and so early history is not very well known. He came to us with a sudden explosion in his hyperactivity, his impulsivity, his aggression, and the kind of violence that he started displaying towards members of the family. Now, this child was a child with attention deficit and hyperactivity disorder. He did have oppositional defiance disorder as well, but the point was that there was a sudden change in the behavior. Now, sudden changes in behavior can be for biological reasons. Something happened to provoke a sudden change in behavior, for example, a seizure. Or, for example, with Tourette's, you see pediatric autoimmune disorders associated with streptococcal infection, what we call PANDAS. And typically, when you ask if there's a change in behavior in a child with Tourette's, sometimes even children with ADHD, there's a history of a minor streptococcal infection that preceded that behavior. Or there's a history of having had a seizure or a new event which preceded the change in behavior. So that's biological. But in this case, the problems were psychosocial. And two things had happened. One was that he had probably become aware of his adopted status. The family had not appropriately shared it with him until that point in time, and he kind of discovered it perhaps through extended family and interactions that happen in people's homes. The second was that his father got transferred out, and his father had moved to another city. And essentially, therefore, there were psychosocial reasons why this child had a sudden change in his behavior. And a lot of the intervention that resulted in bringing control over that change in behavior, he continues to be a child with ADHD, he continues to have oppositional defiance, so you can't take away the baseline, but the violence, the severe aggression came down once an intervention was done for those changes, i.e., he was finding his father's weekly visits home very difficult to cope with. He would become much worse on the weekend when the father was there. Then he would go back to being slightly more normal. He found dealing with his maternal grandmother who lived in the house very difficult. Shubha is nodding because she looked after the child, so we'd probably ask you to say what you did with him. And the other thing, of course, was how do you educate this child, or how do you educate the parents to work with this child about his adoptive status? Because that is actually a very, very challenging piece of information for a preteen to deal with. Learning that what you took for granted as normal, these are my parents, this is my biological family, to I don't know who I was born to and I don't know who my biological parents were. It's a tremendous, shock to anybody's system. So how do you then, work with the parents to help them work with the child? These became the key issues. Maybe I should ask Shubha, who's a child behavior therapist and social worker, to say a few words about how she dealt with this particular case.
It was very traumatic because we couldn't build a rapport with him. So we started with rapport building sessions. I think I spent about 5 sessions. He has an enormous fascination for cars. He would be able to tell you about any kind of model, which year it came out. So we started working on those lines. So we found out the things which he really liked. The next thing which fascinated him a lot was mythological stories. So that was another angle we started exploring. Then slowly we brought him into graded assignments, then scheduling of tasks, and then we started with positive reinforcements, and then we moved on to negative. Time out didn't work with him because he was much older, in a much older bracket. Then we started asking him to maintain a thought log, triggers of what brought on this kind of explosive behavior. We realized there was a lot of inconsistency in disciplining at home. The dad would randomly promise him things, and it was, if you win this bet, I'll get you anything. The anything was never specified. So that would lead to explosive behavior at home when his dad came. So we had a couple of sessions where we worked with the parents, and later on we slowly moved on to a bit of art therapy. I'm not very well trained in art therapy, but then kind of it helped with him because we used to ask him to do a couple of things, color and things like that, and would ask him to give us a feedback on what he felt. So that kind of settled him down a bit. And now what what the feedback the mother's been giving us is he's settled down quite a bit in the school also. He doesn't stay in Chennai, he stays in Trichy. But he's finding academics very difficult, so there are issues there. So at times, pressure of academics is bringing out a bit of explosion in him, but otherwise his peer interaction. Yeah, we did have a lot of role play and mentoring also with him, because he had a lot of issues with peers. He couldn't get along with kids of his age group, so we had a kid of his age group mentor him, talk to him, so we did a lot of mentoring and role play also with him. Thank you.
The diagnosis and presenting in one way or another the concept of having a chronic disease or having a progressive disease can have a tremendous impact psychologically, which then can have an impact on the manifestations of the disease. The other thing that we know that I think we learn maybe not well enough, during my training in movement disorders, I spent a lot of time taking care of adults with Parkinson's disease. And a sure way to make Parkinson's disease symptoms worse is for the patient to become constipated. And we learn that from the rehab physicians all the time. Children with cerebral palsy, children with other kinds of movement limiting disorders, their symptoms often get worse with some kind of non-specific physical stressors. So it can be emotional stressors, it can be physical stressors. We've heard about the role that transient infection can play in the worsening of symptoms. These are all things that certainly we know about. But sometimes the best way to make some of these things better is to really focus on the exacerbating factors rather than on the specific symptoms. Just one other example we see a lot in our families with Batten disease. And this is a common thing that's not very well understood and not very well described, but there's it kind of falls into the category of what we sometimes call survivor guilt. When a child has Duchenne muscular dystrophy, for example, the siblings of that child, especially as the child with Duchenne gets older and more debilitated and ultimately dies, the siblings often feel guilty. They feel, why me? Why not me? Why did that happen to my brother? That's very unfair, and they often feel guilty. Now, if you're in a situation where you also have a neurologic condition yourself, often that will get worse in just that setting of the stresses that come with having other family members. We see a lot of genetic disorders. And when you are a younger child and you see your older sibling going through a terrible time, and you see that is your future, that alone can make your quality of life worse and can make your symptoms worse. And that can also hold for when your older sibling has either passed away or has become non-communicative. It can make a big difference. So I think those psychosocial factors and physical factors all play a role, particularly in the genetic conditions that many of us see a lot of. The other thing just to keep in mind is, we know sometimes our treatments can have effects too. So one of the findings from some of the early epilepsy surgery studies, when you cure temporal lobe epilepsy with a temporal lobe resection, often the patient and the patient's parents mourn the loss of the epilepsy, because their whole life had been focused around taking care of this person who had frequent seizures, and particularly when the surgery is done in adulthood, now all of a sudden the disability is gone. The whole infrastructure is no longer necessary because the adult parents don't have to take care of their adult child anymore because they're not having seizures anymore, and they have to completely learn a whole different way of living and interacting with each other that's no longer based on the disability or the disease. It's based on having had that in the past and now it's gone. And so as we are developing treatments, effective treatments for many of our disorders, we're seeing that once it's gone, and this happens with children with leukemia too, is once your treatment's over, you had all this time and energy invested into it. The parents invested all this time and energy into helping their child to get over this potentially fatal disease, and then it's gone, and now what do you do? And again, I think this is something where interacting with and working with our colleagues in all of these areas can be very helpful.
Perhaps I'll add just one more shared thought along those lines, which concern pediatricians and certainly people who look after children with illness, the other child in the family or other children in the family are often neglected. And as a consequence of that, there can be other problems. Like, for example, I have seen children with epilepsy whose siblings develop non-epileptic seizures. Often the concern is, oh my God, does this child also have epilepsy? And then it turns out that no, it's attention-seeking behavior because the child feels marginalized, neglected, has no relationship with the parents because all the focus is on the ill child. So very often pediatric neurological and neuropsychiatric disorders are disorders of families. They're not disorders of individuals. And you really have to look after the whole family, not just the person who's affected. And I think that this is something that perhaps we all need to think about. So having shared that, perhaps we should open it up for some questions, comments, shared experiences. I see a hand going up in the back.
First of all, as a way of introduction, I'm a developmental pediatrician from CMC Vellore. There are a few things. I've been working with children with developmental needs, mainly neurological, for the last few years. There are a few things, there are one or two points I'd like to raise. First thing is, unfortunately, most of the therapy that we have in India is doctor-centric. For example, let me take a prototype of autism. Now, autism, actually, in truth, the doctors, be it a pediatrician or a neurologist or a psychiatrist, the doctors which actually contribute the least. And at various points in time, it will be various other therapists, maybe occupational therapists, behavior therapists, teachers, who will take the lead in this. So it's been a humbling experience for me to realize that I'm not the one who actually looks after the child. It's somebody else who has to look after the child, and the therapy is probably a long time, and it changes. The focus keeps changing. What you need to do at various points in time is different. In an older child, you're concentrating on education. Maybe in a younger child, it's probably an occupational therapist who has to work. Like Madam said about the behavior therapy, it's very important to realize as doctors that most of the time, we are not the ones who are actually helping the child. That's one point. The second point is the standard of care. If you look at Indian pediatrics, for example, I'm a trained pediatrician. You have consensus guidelines coming out, but you don't have consensus guidelines for treatment. How do you treat autism? How do you treat CP? You don't have consensus guidelines. That's something which has to be emphasized, because the natural tendency is to believe we cannot do anything for these children. Actually, you can do tremendously for these children. And the reason is probably ignorance that you cannot do anything that lets these children go. Even if it's a spastic quadriplegic child, there is so much we can do. There's so much we can do with it. There are so many problems which go unidentified. The third thing, I will not talk, there's another thing I want to say, is a lack of standardized assessment tools, whether it's for behavior, whether it's even for developmental assessments. We do not have cultural specific developmental tools. All of us, what we use are what we borrowed from whether it's if it's a developmental assessment like a Bailey or a Griffith, they're not culture specific. We do not have culture specific tools for Indian illnesses, like, for example, and what we use in our hospital for developmental assessment for an autistic child is a Griffith or a Bailey, which is not really the tool that should be used, but we do not have anything else. So it's high time that we realize that there are lots of people involved, and most important, the parents. And it's high time that we develop our own tools. And most important, lack of communication. I'm blessed to work in a setup with multiple disciplines. But when I see other children I see that you have an occupational therapist working with one child who doesn't have any idea what the speech therapist is doing, who does not have any idea what the psychologist is doing. And you'll end up, they either will be working, for example, the occupational therapist will be working on the child's oromotor skills, which probably is what the speech therapist is doing, but in a totally different way. So it's an absolute lack of communication. So it's time to realize that it's a team which works these children. We need standards of care, and we have to work together.
Thank you. I think those are very useful thoughts.
Good afternoon. My name is Zahir. I'm a pediatric physical therapist working in Kolkata. And in my center, I have from 3 years old child till 18 years autistic children I'm dealing with. And what I can say, like what my fellow sir told me, that it's very true that we are facing a miscommunication between pediatrician, because I have seen children who has reported us at an age of 6 years and have been not diagnosed with PDD or autism. Okay, this is lack of negligence and lack of knowledge, I rather say. So it's a time for us to stand up on the platform and share the information what we have. And one more thing I'm going to ask about CBT, that is cognitive behavioral therapy. Sir, does it work with children who have no language development in autism?
Do you want to answer on CBT?
Yeah.
Yeah, it's on.
Does CBT work in children with autism? That's a good question. I think that the behavioral aspect clearly does. The cognitive part, where you're really changing the way people think, it's hard because those of us who have expressive language, we think in language. And so how do we change the way someone thinks about the world? You know, if you're trying to reduce their anxiety, you explain to them in words. And so I don't know about the cognitive aspects, but certainly behavioral aspects, you know, this is something that goes back to Skinner and before, you know, even going back to Florin's, you know, training pigeons how to do things. Operant conditioning, we can do, it's not language-based, it's providing reinforcement. Although I used to think this was an incredible waste of time, I've become very respectful of people who do functional behavioral analysis. You know, most of the papers written about functional behavioral analysis are N of 1 studies. I have this child who had this behavior that happened in this setting. But if you can identify things that precede a symptom or precede worsening of the symptom, then you can modify that environment or modify those symptoms by modifying that setting. So I think children with PDD or autism, behavioral therapy can be very effective, but it has to be very structured, and that's true for the treatment of tics, that's true for treatment of obsessive compulsive disorder, is these kind of non-creative, regimented, manualized techniques. The creative part comes in figuring out which thing to focus on and which particular strategy will work for this patient. But once you do it, it's, you know, reinforcement and practice and reinforcement and practice. And so I think that is, you know, whatever is reinforcing to the child leads these to be effective.
Yeah, thank you very much. But I have gone through some literature which has shown that those who have echolalia, they have been found with better outcome with CBT. And means that only suggests that those who have, doesn't clearly tell about those who have no language development will not come forward with CBT. Means that is a lack of that research or whatever it is. So that's why I asked you that question of sheer interest. And next thing is like, what about the learning disabilities, which are very common nowadays? So how do, will you explain, how do we, because means nowadays in school going children, everybody are in a rat race in our scenario in India.
I think the question is about learning disabilities, and I think the first problem often is that they go undetected in a number of children, and they are not suspected often enough, they're not tested for often enough, and we are completely unaware. Many of these children end up not being very good performers in school, although they are seemingly quite intelligent, and that usually is the dead giveaway that there is a potential problem of a learning disability. So I think formal assessments of learning ability are definitely recommended when a child is finding it difficult to cope in school, or a child's performance is falling below average, or the child is not making the progress that you expect that child to make. The other kinds of problems that I think we do see is with it, there are some behavioral comorbidities that we often notice in those children. There could be attention deficit and hyperactivity, for example, which is often comorbid with this. The one other problem we come across very frequently is the child who is not doing well in school, but when you actually evaluate the child, the child is tremendously gifted. We've had a few children with IQs of over 140. And they also have some comorbid learning disability, but they also have a load of adjustment problems in school. The gifted child is the other end of the spectrum who actually finds it hard to thrive in a regular school environment, and because the school environment doesn't stimulate that child adequately or doesn't stimulate the right aspects of that child. So I think it's not just, so very often we mix up a learning disability with not being very intelligent. It need not be the case. I think we need to keep that in mind as well. So those are the kind of thoughts that I would think about with these children. See another hand going up?
So one more question just before. Rapid prompt action for autism. This is rapid prompt action for autism. This is a...
Yeah, I don't know anything about that. I'm sorry.
Okay, thank you very much.
But if I could just make one additional comment. I think, we all, I hope we all are starting to change the way we think about a lot of these things. So learning disability, for example, or let's take something that's very physical. Someone who's got a severe tremor. I have children who have ataxic cerebral palsy, for example, cognitively normal, terrible tremor, they cannot write. And it used to be that all of the focus of their therapy and education was to make them be able to write. Well, those of you who have your smartphones and your iPads and, we use our computers, you actually don't have to write so much anymore. And so I think, partly because of that and partly because we've gotten smarter, the focus is more on function rather than the actual act. And I think for learning disabilities as well, I think it's important to work on those things that are key, but at the same time, it comes back to that cognitive behavioral therapy. Can you help the child learn strategies so even if they can't read very efficiently, they can still learn the skills they need to deal in the world? And so I think, focusing more and more on function rather than the individual symptoms is something that I think we're all doing a better job of, but we have to do even better.
I just wanted to share that for learning disabilities, a yeoman service has been done by Amir Khan, Tare Zameen Par. So we have to again have all our parents as professionals, when we see the children and we're evaluating for learning disability, have the parents view that movie, which will educate them because then they understand their child better. So it's again very important that movies, and we are 1 billion people of moviegoers, that would go a long way. So I just wanted to share that. That's a wonderful, wonderful movie.
See two hands going over the back.
The doctor from CMC Vellore have very nicely highlighted what is existing currently in India. I'm a pediatric neurologist practicing in Chennai for the last 2 years, but before that I was in UK for 12 years. So I was a pediatric neurology consultant at Great Ormond Street Children's Hospital. They created a well-established system for neurodisability a long time ago that has been universally applied in United Kingdom for quite some time. Since my arrival here, what I am seeing is everybody is running their own business here, kind of a model where occupational therapy, they will have a business setup or a therapy setup, but that is where the income generation, how many patients I am seeing in my setup, that is how it is running here. Almost 98% I would say, except an institution like CMC Vellore or SRMC Chennai, or maybe VHS. Accessibilities are difficult. Even within the city, I have seen if I suggest go to this therapist, they say it's too far. Rather, we would stay at home. That kind of response sometimes I get, because to carry a disabled child in a regular transport is so difficult. So I think this forum, I'm sure there are a lot of delegates who are interested in neurodisability. Unless people come together and taking our paramedical team together, treating them equally, develop a team in wherever we are working, and that is the only way we can move ahead. Otherwise, the same system will exist for another 10, 20 years like this. So I think maybe I request the fantastic conference convener, Dr. ASK, to consider to take a lead on this area. I think I, as a neurologist, except saying your child got autism, I have nothing to offer to that child. Same thing for a child with learning difficulty. I may say this is the diagnosis. I don't have anything else to offer to you. I need whole other group of professional, I need to get this child better. But that is not happening now. Unless we take efforts to make that happening in a smaller scale to start with and standardize on a later stage, it won't change. That is where maybe future conference could be considered inviting not only the doctors who are interested in neurology, neurodisability, and also the therapist also. And they may feel that we are part of this team and we are treated equal here. And that equality make a huge difference in the outcome of the child I have seen for years in UK. Thank you.
I